And welcome to the TASC 90 webinar for the third quarter of fiscal year 16. This is Tracy Morton. I'm a Senior Program Manager at the National Rural Health Resource Center and Program Manager for the Technical Assistance and Services Center, or TASC, which is the Technical Assistance Center for all 45 state FLEX programs. Welcome to the webinar today, and our topic today will be an update on the strategies for rural hospitals shifting to value-based purchasing and population health. An extremely timely topic, and even more timely as we're a year out from a summit meeting that convened on that particular topic. And there was another summit meeting to identify operational tools and resources, particularly for these strategies, that was just held yesterday and today. So much more to come on this topic over the next year or so. What I'd like to do first is just review the agenda, and then we'll get rolling with a few quick updates from TASC. We'll have an update this afternoon from the Federal Office of Rural Health Policy about what's going on within their organization, as well as what is happening with critical access hospital regulatory issues that we should be aware of. There'll be an update from the Rural Health Value Team on some recent resources and tools available to you in your hospitals and other rural partners in your states. John Gale from the FLEX Monitoring Team is joining us for an update on the work that might be happening within the FLEX Monitoring Team. And then we'll get into the topic today with a group of speakers on providing an update about those strategies for rural hospitals shifting to value-based purchasing and population health. And I'll get into those learning objectives when we get to that particular topic. A quick update from TASC. For state FLEX programs, registration is open for the 2017 FLEX Program Reverse Site Visit in Bethesda, Maryland on July 19th and 20th. If you are planning on attending, you must register, and the registration is available on the website. 2 state FLEX program people per state are planned on attending. If you are interested in bringing an additional staff to the meeting, please contact your project officer first to get the okay, and that's very important for spacing as well. We want to make sure that we can accommodate everyone. You do need to book your lodging separate from that registration, and the event's being held at the Hyatt in Bethesda. The room rate is $172 plus tax per night, and the room block does close on June 23rd, so about a month out from now. So if you're planning on attending, please get your registration completed and book your lodging as well as any other travel requirements that you may need. Any questions or concerns, please contact us at TASC. The other item I wanted to share in this brief update is that there is a virtual knowledge group call on Monday, June 5th at 2 p.m. Central Time, again with John Gale from the FLEX Monitoring Team. And that call will feature Sally Buck and John discussing a framework for high-performing state FLEX programs that's been identified through the FLEX Monitoring Team. So we hope that you can join for that virtual knowledge group call discussion. If you're not available for that webinar, it will, of course, be recorded, and the recording will be placed into the FLEX program forum. So with that short update from TASC, I'd like to turn things over to Sarah Young and Joaquina Scott from the Federal Office of Rural Health Policy for their updates.
Hi, this is Joaquina. I can kick things off with the policy updates that I have provided. And so just a few updates to bring to your attention if you are not already aware of them. The first being the publication of the proposed rule for the fiscal year 2018 hospital inpatient prospective payment system update. A couple of things that we wanted to highlight from a rural perspective for your attention. The first being that the sunsetting of 2 really rural-related programs as of October of this year, if there is no congressional action to continue these programs. The first being the Medicare Dependent Hospital Program, as well as the Low-Volume Hospital Adjustment. So as I noted here, according to CMS estimate, there are about 96 of 158 current MDHs will lose about $119 million. And again, there's going to be a significant decrease in the low volume hospital payments if this program ends with no extension. The other thing I wanted to note is that CMS is making changes to the the DISH payments, particularly the uncompensated care pool. What they're doing is making changes to what's being reported on this worksheet S10 that hospitals have to, indicate what their uncompensated care is. And what they're estimating is that this is basically going to establish a $7 billion pool for uncompensated care. And so what it does is, the way we look at it is that those hospitals that are in your Medicaid expansion states are more likely to get less dollars because they are not going to have much by way of uncompensated care to report on this worksheet versus those hospitals that are in states that did not expand Medicaid. So as I mentioned here, in effect, we see it as a redistribution of this uncompensated care dollars from more urban and Medicaid expansion states to more rural and non-expansion states. So we'll be monitoring that to see what type of comments CMS receives related to this proposed rule, and if it is finalized, what will be the effects for rural hospitals overall. The other thing that I wanted to highlight is that CMS is, through this proposed rule, is what they call de-emphasizing the review of the 96-hour certification requirement for critical access hospitals. So they're instructing the QIUs, the MACs, and the RACs to not conduct the medical record review for the 96-hour rule unless they find evidence of gaming or noncompliance. Also, per this rule, there's an extension of the rural hospital demonstration for 5 years, which was a result of the 21st Century Cures Act. And I have a note, which I'll talk a little bit more about that particular demonstration in a little bit. I also wanted to highlight, though, that they're requiring accrediting organizations with CMS-approved accrediting programs to actually post their survey reports for the last 3 years on their website. So this basically is going to publicize the survey results for about 89% of PPS hospitals and 32% of COS participating in the Medicare program via accreditation. And also, we see this as providing more information to consumers about their care choices. The final thing, well, not final, actually, there's also in this proposed rule the sunsetting of this imputed rural floor policy, which is expiring this year, which basically can increase the wage index related payment to rural hospitals. So, but what this allowed was a few states, and I'm not recalling the states offhand, that were basically not rural. We're continuing to get this exception and getting a payment, a rural payment for the services. And so by this particular policy expiring, those hospitals in states such as, like, I think it's Rhode Island is one, a couple other states, they would no longer be getting this exception that say that they could still qualify as a rural hospital, so effectively adjusting the payments to all other hospitals that are truly in rural areas and states with rural areas. The other thing I think is most notable after saying all of that is that CMS is really attaching to all of their proposed rules, at least from what we've seen this year, or to most of them, what we've seen this year is a request for information. And what they're doing through these various requests for information is asking for overall feedback from the public on reducing the regulatory burden or improving quality of care for hospitals or other providers. So they're opening the door to really hear about what your concerns are, what rural providers' concerns are. My understanding in speaking with some of my CMS colleagues is that, definitely use this as an opportunity to raise concerns with CMS, even if, for example, at the National Rural Health Association annual conference earlier this month when Carol Blackford at CMS was providing an update on some of the Medicare policies. Someone asked the question, unrelated to the Medicare policy updates, but related more so to CMS, wanting CMS to provide more guidance to MCOs on some of the things that they're doing and how they work with rural providers. And her response was, well, you know, we have these RFIs out here, particularly one for the IPPS. You can submit that comment as part of this RFI, and it would go to the appropriate person in CMS to look at and consider. So I say all that to say that as you see these opportunities attached to these proposed rules for CMS, you definitely use that, see it as an opportunity and use it as a means to provide input to CMS for various Medicare policy issues or maybe non-Medicare policy issues as you see fit. So the other thing before I stop and ask for quick questions is the Rural Community Hospital demonstration. So as you may see here, those applications were due as of last week, but I did want to provide that as a reference, mainly the link as a reference where you could see their third solicitation for applications. And again, this demonstration is really targeting your small rural hospitals that are not small enough to be a critical access hospital, but will still need more so financial help in providing their inpatient services. So it's really testing that cost-based payment methodology that critical access hospitals have, but is for slightly larger hospitals, but they have to have fewer than 51 acute care inpatient beds. So those hospitals that were previously a part of this demonstration that has been ongoing for some years now, they can come back and apply for this same demonstration, and my understanding is about 20 hospitals or 21 hospitals. CMS will take up to 30 hospitals under this continued demonstration, so that really leaves about a handful of hospitals new hospitals that may not have been participating in this demonstration that could possibly be awarded to participate in the demonstration. So I'll stop right there before I move on to see if there are any quick questions related to the IPPS update or the Rural Community Hospital demonstration. Or if I should, you can let me know if I should just continue and take questions later.
Any questions at all for Joaquina?
As a reminder, you may need to use *2 to unmute.
Okay. Well, I'll continue as folks may or may not be unmuting their phone. The other thing I want to highlight was the Federal Communications Commission is seeking public comment. Again, that deadline is today. And basically, this will not be the only opportunity. If this is your first time possibly reading about this or hearing about this opportunity, this is not going to be the only time where rural providers can provide feedback on this program. This is like before they do rulemaking, they put out a public notice seeking comment, and they're seeking comment on a broad range of issues from the data to information on regulatory, policy, technical infrastructure issues related to broadband-enabled healthcare. So included in this request for comments is how to strengthen their rural healthcare program, which supports the telecommunications and broadband services to improve healthcare in rural communities. So some of the things that we thought about that you may want to consider if you have a chance to read through the public notice more closely are some key policy issues that are not necessarily, let's key policy issues, including but not limited to ensuring that eligible safety net providers can access the program funding. Currently, that funding is capped at $400 million, and so you may want to consider, is that particular cap adequate, and if the FCC should consider reassessing that particular dollar amount, and also looking at reducing the administrative complexity for the program. So again, even though the comment period closes now, they're going to, my understanding is that there's going to be another comment period once they gather the comments from this first opportunity where you can respond to the comments that they received as well. So it's definitely multiple steps in this process, and we just wanted to make this particular opportunity, we wanted to bring this to your attention because the broadband definitely has broad implications for rural communities. For the quality payment program update, wanted to just let you know that CMS now, they're doing a lot actually. So one, between the end of April through May, they're going to be sending out the letters to providers that are eligible for the MIPS program. And so you may or may not have heard of your providers in your areas or in your state actually saying they received the letter or not. But basically this letter went to all providers at the tax identification number level, and what they did within this letter is indicated by the NPI as to whether or not a particular clinician that's practicing at an organization, at a hospital or clinic or FQAC is eligible or not eligible based on how much they actually bill for Medicare Part B services or how many Medicare Part B patients they may actually see in a particular year. So in addition to those letters, they actually updated the website with right on the first page of the Quality Payment Program website is a tool where you can just kind of click to see if you are eligible for the MIPS program. There's also a reminder that, again, they've already rolled out the technical assistance or awarded the technical assistance contract for small and rural providers, and so they're starting to track the type of technical assistance those contractors are receiving and the types of or having to provide, and the types of questions that they're receiving as well too. They're tracking the types of questions that they received in their helpline as well as their email inbox too. So if there are questions related to your participation, or if a provider has questions related to their participation in MIPS, CMS is definitely asking that provider reaches out via email or by phone to receive the technical assistance that they need. And the final thing that I wanted to mention was that CMS recently published a notice that they received an application from the Joint Commission for continued approval of their COP accreditation program. This is more of a standardized process. The Joint Commission has already been approved for this, so this will be a continuation of their program and being able to provide accreditation for critical access hospitals. Currently, this program is set to expire in November of this year, November 21st of this year. So they basically submitted an application to continue providing that program. So if you do want to provide comments related to their overall CA accreditation program, or write to CMS to consider maybe rural considerations for how they can improve that particular program, you are able to do so by June 18, 2017, and I have provided several hyperlinks within this document for you to receive more information. So I'll stop there to see if there are any questions.
Thanks, Joaquina. Any questions for Joaquina? Okay, well, thank you very much for the helpful document that we can all use. And again, you can download those items from the bottom left corner in the file share area. And with that, I'll turn things over to Sarah Young. Thanks, Sarah, for joining us today.
Hi, Tracy, and hello, everyone. As you know, I'm Program Coordinator here in the Federal Office of Rural Health Policy for the FLEX grant, and I want to hit just a couple of updates and let you know to watch for more information. First, everyone, thank you for reviewing the latest proposed rule from CMS, Joaquina. As you know, if you've been part of this for a while, the Inpatient Prospective Payment System proposed rule and the Outpatient Prospective Payment proposed rule are some of the biggest Medicare updates every year that affect CAUSE and other rural hospitals. So it's important that people pay attention to those. And if I remember the calendar right, the Outpatient proposed rule is likely to be published in late June or early July. As you've all probably seen by now, the President's budget was released yesterday. These are the administration's proposed budget figures for fiscal year 2018, which reflects new spending priorities. The FY18 budget is a request that will go to Congress, and they can factor it into their decision-making process. I want to remind everyone that this proposal is the FY18 budget, so it does not affect fiscal year 2017 awards, which are in process. In addition, more closely related to FLEX activities, I hope everyone saw the Save the Date that I sent out earlier today on the FLEX program listserv for a webinar next Thursday, June 1st at 3 p.m. to review the FLEX funding supplemental opportunity that we expect to be released on June 1st. As you probably saw, there was an additional $2 million appropriated by Congress in the FY17 FLEX funds with some specific instructions about targeting that money. So please put a hold on your calendar, and there will be more information about how to join that webinar coming out shortly. The final thing I want to put on everyone's radar is now that we have finished the NCC applications, or at least FLEX grantees have finished the NCC applications, your project officers are busy reviewing them, we are also starting to gear up to collect information and plan the FLEX future direction for the fiscal year 2018 and future cycles. So there will be a lot of requests for information and opportunities for comment on different issues within the FLEX program coming out over the next several months. Please read the, please watch the listserv and read the Rural Route newsletter and look for opportunities. Look for, so you're hearing all of those information opportunities. And don't hesitate to reach out to me, or if you have any questions, feel like you're missing something, or you have specific ideas. That was all I wanted to say. Joaquina, if you're still on, can you answer Chuck's question? Did the CMS notice to physicians regarding Part B participation include contact information for the physicians' respective technical assistance contractors for the quality payment program?
No, thank you, Sarah. I think it just included the general support center number and the email address, but not the particular contractor that would be affiliated with that particular provider for that region. CMS did provide like a one-pager, and I'm happy to, as a follow-up, send that as a reference where they displayed via the map which contractors will be covering which regional areas, if that's something that you're interested in having.
Great, thanks. If you could send that to me, Joaquina, I will post it in the Flex forum, so Chuck and anyone else who's interested can find it. So basically my takeaway is pay attention to the newsletter and the mailing list over the coming months, because we're going to have a lot of information sharing and information gathering activities happening. Thank you, everyone.
Thanks, Sarah. Much appreciated. And so moving along with the agenda, we'll turn things over to Carla Wang, who is with Stratus Health and one of the partners that's working on the Rural Health Value Program. And I'll let Carla kind of explain quickly what Rural Health Value is and share with us the awesome tools today. Thanks, Carla.
Absolutely. Thanks, Tracy. And so no, we are not talking about MBQuip, even though that's what most of you are used to hearing from me on. I do actually work on some other things. So it's been my pleasure to be a part of the Rural Health Value Team, which is funded by the Federal Office of Rural Health Policy. It's a partnership between Stratus Health and the Rupert Center for Health Policy Analysis at the University of Iowa. So Clint McKinney and Keith Mueller are the two primaries from the University of Iowa on that team. It's kind of a mix of research, technical assistance, and fact-finding. We do a lot of work trying to understand what is best practice out there around shifting to value and try to capture that information and share that information. So what I have for you today is just a brief highlight of some of the tools and resources that the Rural Health Value Team has available that we thought were the most relevant for critical access hospitals. So we don't focus specifically on critical access hospitals in the Rural Health Value Program, but certainly they are a hub of activity and healthcare in the rural communities. So many of the tools are addressed there. So the very top of the list, there's two that I want to highlight that are new. We have a critical access hospital financial pro forma for shared savings available that's just recently released. It's an Excel-based financial modeling tool, and it was put together for us primarily by Premier. They used a lot of their database to help with some of the modeling, and we also had some great input on that resource from the folks at Syme Johnson, Whiffley, and Stroudwater. So there's been lots of good brains working on that information, and it is really just available as an overview tool that critical access hospitals can plug some of their financial data into and start to get a sense of what a shared savings contract might look like for them. The one right beneath that is also a financial modeling tool, and that tool really assumes that there is no change. If you continue under a cost-based fee-for-service environment, what might that look like? With the other programs and pressures on inpatient care and looking at emergency department services going on from different quality incentive programs, it's just another tool to help folks look at what those projections might look like. Other tools and resources available there, we also did recently put together a guide to help folks, critical access hospitals, think through using a market-based approach, how they can demonstrate their value to potential partners such as networks, affiliations, tertiary care centers, those types of things. Some resources around provider engagement, physician engagement, a cheat sheet to help hospitals engage their board and community in value-based conversations, and we also have a fairly comprehensive value-based care assessment tool that's really intended to be utilized in a strategic planning capacity. It's not a quick checklist. It's a pretty comprehensive tool that can be used as part of a strategic planning process. There's a handful of briefs and reports also available on the flip side of that page. The top one I think might be most interesting to you guys as flex programs, and that's a catalog of value-based initiatives for rural providers. There's a lot of information and a lot of programs coming out from CMMI and other areas within HHS. So that catalog just has quick one-page summaries of kind of key information about those different programs. So if somebody, one of your hospitals asks about program X, hopefully it is included in that guide and it'll point you to the right place. So that's one of the resources that's available. We're continually adding new programs and updating information in that guide. So that's really intended to be a resource as a quick list for you rather than having to dig through and try to find everything on the CMMI website. We've tried to summarize information that's relevant for rural providers. And then the last thing I'll highlight is just that we have also, as part of the program, done more than, I think we're almost actually just about to release our 16th profile. We've done snapshots, finding information from what's going on in different rural communities that are doing innovative things around healthcare. I've highlighted just a couple of them on this resource sheet, but there's several more that helps give folks ideas about what kind of things different rural communities are doing across the country to address value and improve care connections across their facilities. So that's all I have, just a quick resource update. Remind you that there's some new stuff out there and that rural health value resources are out there. If you have questions, please go ahead and let me know. And otherwise, Tracy, I'll pass it back to you.
Great, thanks, Carla. And Chuck, I see your question about whether or not these tools are available on the National Rural Health Resource Center website. Some of them are, but we're trying not to be too duplicative. So on the screen right there, there's the ruralhealthvalue.org website. That's where all of these tools are certainly housed. So we're trying to cross-pollinate as we can, but also not make ourselves crazy with having to maintain all the content that somebody else that's a close partner is already maintaining. So
yeah,
please,
and these are all hyperlinked too.
Bookmark.
Yeah, and if you download it, these are all hyperlinks. And not everything that Rural Health Value do is relative to critical access hospitals, so that's one of the other pieces of why we don't have things double posted everywhere.
Great.
Yep.
Well, thanks so much for joining us, Carla. We really appreciate it.
Yep, thank you.
Okay, and great. And then now I'd like to welcome John Gale for the first time of the conversation today for any updates he might have from the Flex Monitoring team. John, do you have any updates about Flex Monitoring in general?
Just, excuse me, just a few minor points. If you've been checking the FMT website, we've posted in the last few months a few new reports and data summaries. The CAH Financial Indicators report was posted in March, along with the Financial Indicators Primer and Calculator Toolkit. Just before that, we had also updated the Hospital Compare Quality Measures data summary, as well as the HCAP results summaries for 2015, and those were both done by the University of Minnesota and our colleagues at North Carolina and the Financial Indicators. Beyond that, we're updating now, adding new data to the Compass website. One of the struggles, if you will, or I mean challenges for us has been sort of updating and merging the disparate data sets that are being used to populate Compass. So you have the CH cost report data, financial indicators, quality reports. We're submitting community measures from the AHA hospital survey, from hospital, the Robert Wood Johnson county health rankings, and individual measures from the hospitals themselves on charity care and bad debt. So it's a challenge to make them all work the same way, and so that you can actually analyze them and pull them up on a hospital basis and create some comparison in peer groups. But we're moving forward. We're adding the 2014 AHA data to the community side. It's underway now, and we'll be adding the 2015 as soon as we receive the data set from the Hospital Association. So we're working to make sure that's as up to date as possible, and welcome any feedback and questions folks might have. Finally, we're continuing and we're moving forward on our evaluation work of the EMS assessment tools that have been done. We'll be working on a policy brief this summer that will be out. And then we're continuing the 2-year look at the innovative models. And we had a few of our programs we had Scott Daniels from Hawaii, Pat from Illinois, and Michelle Mills from Colorado participating with us in a session in San Diego. That work will be out this summer, probably towards as well as we put the policy briefs together. And that's all I have. If there are any questions.
Great. Thanks, John. Any questions for John? It's, again, *2 to unmute your line. Okay. And for those that will be attending the reverse site visit, Flex Monitoring team will certainly be presenting some content at the reverse site visit as well. And we encourage you to go to those sessions and also to use Compass, because that's an amazing product that you guys have built for all of us. So thank you.
Oh, you're welcome.
So we're gonna shift now into kind of our topic for today, and that's an update on the strategies for rural hospitals that are shifting to value-based purchasing and population health. So for those that aren't familiar with the National Rural Health Resource Center, we're a nonprofit organization. We're based in Duluth, Minnesota, and we're dedicated to sustaining and improving healthcare in rural communities. One of the programs of the National Rural Health Resource Center is the Technical Assistance and Services Center, which operates under a cooperative agreement with the Federal Office of Rural Health Policy to support the state flex programs. And that's where the work of the TASC 90 webinar here today, as well as the summit, happened last year. So the session today here about the summit findings and these strategies is, first we'll start with reviewing what happened at the summit and what the 8 strategies were that were identified. Then we're going to hear from some experts and some peers on the call about their work out in the field, either in advising critical access hospitals, working with their state flex program, and addressing the critical access hospital needs. And then again from John Gale, listening to research updates on the observations seen in the field from the flex monitoring team's perspective. So the speakers today include myself, Tracy Morton, as well as Jeff Johnson, who is a partner in healthcare practice at Whipley. Jeff has more than 25 years of experience working with critical access hospitals and in rural healthcare, and he is really a trusted expert and advisor about rural hospital finance and financial strategies, and has been a long-term advisor to TASC in the Flex program and providing support. We'll also hear from Greg Rosenthal, and you may be familiar with Greg as he's kind of a fellow Flex program person at the state level. He's a Rural Hospital Improvement Director for the Utah Hospital Association, and he serves as a subcontractor and a Flex coordinator with the Utah State Office of Rural Health. And Greg has been working with the Flex program since 2011. And as we've already heard from John Gale, we'll hear from John again. John is a research associate at the Maine Rural Health Research Center with the University of Southern Maine. And John's been working there since 1999. He has a wide range of areas of expertise and research interests, including things like community benefit, health information technology, substance abuse, operational improvement, among many other topics. So welcome, and thank you so much for our speakers for agreeing to participate today. So kind of an overview of what happened at this summit. This summit, like I mentioned earlier, occurred in May of 2016, and it was titled a Financial Leadership Summit, where we sought and brought together a group of experts to identify what are the strategies that rural hospitals really can utilize to transform into value-based purchasing and value-based payments, as well as population health. So the summit defines some market forces that are happening, either good or bad right now in the environment, and some that are persisting as well. It identified those key operational strategies and then highlighted success stories and lessons learned. It built upon Critical Access Hospital Financial Leadership Summit that was held in 2012 that I know for certain that Jeff Johnson was at, and as well as the Rural Hospital Toolkit for Transitioning to Value-Based Systems that came out from the Small Rural Hospital Transitions Project, another federal Office of Rural Health Policy program, and that toolkit was released last year. All those things are linked on the screen. If you are not familiar with those bottom two tools and resources, you should be familiar. So please take a look at them. They're excellent tools for your program and for your hospital. So make sure you familiarize yourself with those as they're timely. They'll provide a foundation of awareness if you're interested or need to learn more about financial information, and certainly provide some great direction and tools moving forward as we move into value-based payments. So as I mentioned, the summit talked about some of the driving forces and transition challenges, and on the left side of your screen are those driving market forces, including things like state innovation model grants and the Centers for Medicare and Medicaid Innovation Models, accountable care organizations, some of the federal legislation that came out like MACRA and MIPS, as well as network initiatives and just general increase in awareness, and of course some reduction in some payments that were happening in the fee-for-service arena. Of course, our critical access hospitals primarily work in cost-based reimbursement, but there are some fee-for-service components to critical access hospitals and their other entities. There was, of course, some challenges, and many of these challenges that you see here on the screen are nothing new in the critical access hospital, the rural payment arena that's existed for many, many years, things like recruitment and retention, reimbursement reductions, access to data, and knowing how to even use the data. And one thing, of course, that's been introduced over the last few years is that confusion due to this transition process. So the group talked about these things and then went forward with identifying 8 strategies that they divided into 3 time frames: immediate, short-term, and long-term. And as you can see with immediate that's listed up there, they were saying that these are things that should happen within the next 18 months. This summit was a year ago, and so the 18 months are getting close to the end of that. So if your hospitals and your rural facilities are not starting to think about some of these strategies, now is certainly the time to do so, and we'll walk through quickly what these strategies are. So as far as immediate strategies, these are the things that, the strategies that are designed to position a hospital both financially and operationally for the next stage of value-based payment methods. And they include some of the things that are they're nothing earth-shattering about improving financial, critical, and operational efficiency. I think all of our facilities are working on that daily, but it is a fundamental element of being able to prepare yourself further in the future. Engaging and educating those leaders and those staff, making sure everybody is on board and aware of what's happening within the facility. And of course, educating and partners with physicians and other primary care providers. That primary care structure is really the backbone of population health, and it's one asset that we really have working very well for us in rural areas, as primary care is kind of the bread and butter of the work that we do there. It is fundamental with establishing those relationships with the communities, is providing that primary care. So partnering with the physicians and other care providers and making sure that they are feeling like a valued member of the team is very, very important. The next set of strategies then were short-term strategies, so within 18 to 36 months. And these include things like aligning the community health needs that many of our 501c3 nonprofit hospitals are identifying through their community health needs assessments, and identifying data and other resources that might be available to help them. Developing care transition teams. As we know, many or not all of the care that is needed for our community members can occur in the rural environment. Sometimes we need to seek specialty care or need to be transported elsewhere. So those care transition teams, either outside of the community or within the community, are very, very important. And then collecting, managing, and acting on that patient data, which sometimes can be a bit of a challenge to get that expertise or build that knowledge within the rural facilities. And then the last set of strategies are long-term strategies. So these are 3 years or more out. And these strategies become more important as the payment system approaches that total value-based payment and capitated payment plans. And they include things like collaborating with other rural hospitals and larger regional health systems, documenting outcomes and, of course, demonstrating value, which is nothing new to us here in the FLEX program as we work to do that as well. So for more details about the full report, it's linked there on the screen, including, as I mentioned, some of those success stories and lessons learned. There's also a webinar playback when this report was first launched that's linked as well, that includes kind of an overview of the full findings and the tools and resources, and really goes into the description of what was found at that summit and why it's important. But what we're going to do today here is transition first here to hearing from Jeff Johnson, who's going to talk about his experience in the field working with critical access hospitals as he's trying and working with them and discussing these strategies and how they're actually making them work. So I'll transfer things over here to you, Jeff. Thank you so much for joining us.
Hey, can you hear me okay?
Yep, I can.
Okay, good. Well, thanks for having me. Certainly has been quite a busy year in the last year with the onset of MACRA, and then recently how to implement MACRA, if you can still try to understand how we're going to do that. So it's a pretty complex program. However, are you going to flip the slides for me, Tracy, or?
You can actually do that in the bottom left corner if you choose to do so. There's some arrows. Otherwise, I'm sure Bridget would be happy.
So you're giving me control.
You.
Okay, excellent.
Yep.
All right, great, thanks. Well, yeah, so to Tracy's point, one of the things we're seeing, we're kind of working in that 0 to 18 months from the time we met. Things were kind of happening already, and there's a lot of organizations, a lot of rural hospitals that are kind of well ahead of the curve. There's some that are kind of in the midst of it, and they're trying to find their way. And of course, there's those that today still haven't, figured it out because, all this value-based stuff doesn't apply to me type of mentality, when in fact it will, and it does touch those organizations. As you know, critical access hospitals and rural health clinics are not subject to the payment penalties and those types of things. So they kind of, I hate to use the term put your head in the sand, but I'll use it because that does happen with a lot of organizations. And I think our goal is really to try to transition and change, to get organizations to change and look forward. And kind of that 0 to 18 months is, as Tracy mentioned, the strategy here is really just to position the hospital, the health system financially and operationally for the next, as value-based or the payment models change, alternative payment models change, because even though they may not be applicable now, they certainly will be in the future. I just feel that it's inevitable that there will be, payment incentives potentially, maybe not cuts, but certainly incentives for some of these, for critical access hospitals and rural health clinics to maybe get a little bit more compensation for the value of the services they're providing. So one of the things we've been seeing, and we see this often, but we have seen physician-hospital integration, especially in the cost-based pickup. We've seen a big pickup in integration, primarily in the primary care, just to really prop up that, the primary care physicians are typically kind of the patient care managers, if you will, kind of back to the gatekeepers, if you want to use the term, back in the capitated days. But that's certainly true now as we move forward in managing the care, transition it from, kind of the eat what you kill to more of a managing the care to keep them out of the hospital, so to speak. And so one of the things we've seen is, as this has happened, we've seen even a prop up in the physician compensation, and primarily to recruit and retain these primary care providers in these areas of underserved health professional shortage areas and so forth. We know that, I think that the key when we talk about, access to care, it's not necessarily whether you have insurance or not. It's really, is there providers in these rural communities to provide the care? And that, to me, is really the access to care component. Can you guys still hear me okay, Tracy?
Yes, we can.
Okay, I just lost the presentation a little bit here. I don't know if that was on my end or not. But either way, so we're seeing a lot of that, and we're also seeing that these hospitals and physicians with consultants and other attorneys and so forth getting creative and trying to kind of make these integrations happen a little bit more with a little less capital outlay from the hospital, because we know a lot of hospitals have not a lot of capital. Some have more capital than others, but a lot of them don't. And so we're seeing creative joint ventures, virtual joint venture type things, methods to defer the compensation as a hospitals maybe acquire, bring in physician practices. Oftentimes there's a mechanism where there's where you have to purchase the practice, where there might be some like goodwill or to that type of thinking, but we're trying to get more away from that and try to defer the compensation or prop up their compensation. We're also seeing a lot of collaboration between larger health systems and small hospitals, even more so today, not necessarily from the standpoint of taking over or, taking over the critical access hospital, but really just collaborating in a number of different ways, and I'll talk a little bit about those in a second. And not just within large hospital to small hospital, but within small hospital to small hospital, which is what Tracy was referring to, maybe in the 3 to 5 year or the next 3-year type of time frame. And as we talk through these things too, the physician hospital cultures are very different. And so there's been a lot of traction and a lot of needed expertise to help build kind of trust between the hospital side and the physicians themselves, motivating the physicians, as you've probably read and seen in the news, probably more recently, but it's not new news, is just the burnout rate for physicians in primary care and specialty care both. And so you're starting to see a little bit of expertise in that kind of behavioral management area to try and motivate the physicians and the hospitals to work more better together and to create incentives for those physicians, and also to eliminate those barriers to change when you bring the two parties together. The other thing that we're seeing kind of related to that is just physician compensation redesign. This is key because we need to start linking the payment model to the way that the payment model will look into the future. So you're starting to see a little bit more alignment with the compensation plan with the payment models that are being paid by Medicare and other insurance, because this is not just a Medicare program. Other commercial type insurances are starting to adapt and continue to bring value-based payment models into the equation. So incorporating the value-based payment domains, clinical process of care, panel size, different things like that, the patient experience, patient satisfaction, for instance, historically has been measured. Typically in a physician group, it's measured at the individual physician level. Well, we're seeing a transition of maybe measuring that at a group level to kind of hold each of the providers accountable to one another. And then part of this is, in the last bullet point there, in terms of kind of the step to balance the quantitative versus the qualitative. The quantitative, when I talk about quantitative, I'm really talking about kind of the typical compensation model where the more RVUs you produce, the more compensation you get. And so we're trying to bring in the qualitative factors such as the value-based payment domains, the patient experience, outcomes, efficiency, quality of care, those types of things, bringing those in, and maybe making that part of the overall compensation where maybe it was, 80% of it was a base salary and 20% was incentive purely based on production. Start to carve back some of that where maybe 5% of it's based on some what I call qualitative aspects of the plan to start to incorporate quality metrics and things like that. Okay. And so a couple of things here. Again, if you recall from my initial statements, kind of the immediate strategy is to really position the hospital financially and operationally for the next stage of value-based payments. It's kind of as I think Eric Schell, one of our not part of WIFLE, but a colleague I've worked with in the past frequently, that crossing the shaky bridge, so to speak, you kind of have to make sure that you have all your ducks and all your operational efficiency before you can try to make it across that bridge to start to encounter what's coming down the future. So increasing activity in charge master reviews, making sure, not just from a compliance standpoint, it's easy to look at a charge master review and make sure you're complying with all the codes, but really focus on the charge capture piece of it, making sure that those services that you're billing for all the services that you're providing and getting reimbursed for that, not just from Medicare, Medicaid, but other payers as well. Couple other items here: increased activity in the CA affiliations, kind of alluded to that in the previous slide, but really a couple things here. More, we're seeing a lot more in this area, initiatives to support clinical practices and share, in terms of sharing and adapting and further developing comprehensive quality improvement strategies. So we're seeing alliances between several hospitals and even some of the collaboratives that are in the various states, the ICANN, the critical access hospital networks that develop in the states. Starting to see them collaborate a little bit more, not just in the kind of the GPO, the group purchasing stuff, but some of these other items, and leveraging flex grant money to share across all organizations versus having just one apply for the funds. Getting assistance from consultants to help them with those strategies, and another item is assistance with data analytics in terms of maybe pooling resources to engage or hire an IT expert so that you can use that, because as we know, as we look forward with this data, the quality data and so forth, and all these different initiatives happening, data is going to be key to being able to mine that and to understand what to do with it. Let's see, what else here? Some other strategies, I guess, as we look 3 years down the road, continuing to see the development of those patient care teams. Patient care teams might look like, in some organizations, one physician or one non-physician, or like a PA or a nurse practitioner, mid-level practitioner, might have one medical assistant assigned to each of those providers. So, and typically try to minimize the sharing, so that, like, if I was a physician and I have a partner, that I'm always using one, consistently using the same medical assistant, so that you can develop, the thinking of one another, so that that medical assistant knows what I'm thinking, and he or she knows what, and I know what he or she is thinking in terms of the patient care experience. And then oftentimes there's the registered nurse that may have one in a practice that's divided up into 2 or 3 provider teams. Oftentimes we're seeing more and more scribes in these practices, in these patient care teams, just to make sure that they can document, so that document the EHR system. As you know, that younger physicians have a pretty good handle on the EHR systems, but the older physicians typically have a little bit more harder time with those systems. So having a scribe available so that the physician can focus on the patient care and let the scribe do all the data entry certainly helps the process along. And then, as I mentioned before, just data, just data mining will be paramount and identifying the population health outcomes, reviewing that quality data, and so forth. As I mentioned before, hospitals kind of partnering together to share those resources in IT. I was at, and I know Greg was at the conference as well, but Tom Morris, some people were talking about IT at the Utah Flex or Rural Summit last week, and talking about data and the importance of mining the data, and we're seeing some of those organizations starting to partner together, but is there a way of paying for that? And I think I heard Tom say that they're not going to pay him, Tom Morris from the Federal Office of Rural Health. Certainly, they're not going to pay for an FTE, but they might have an ability to, if hospitals come together to share resources, to kind of help fund some of the dollars needed to support the data analytics that will be needed in the future for these value-based purchasing programs. So I'll take a breath there. And does anyone have any questions?
Thanks, Jeff. That's great.
Okay, I don't see any questions, but I'll be on the line the rest of the time, so if something pops up at the end, I can certainly try and address that.
Great, yeah, absolutely. And it's exciting to hear about the things that you're seeing from the field, too. It's nice to see that there's movement happening, and there's literal, kind of bursts of innovation that are happening here, there, and kind of all over the country, too. So it's not just, I know you're based in Spokane, but it's not just in Spokane or in that, Washington Northeast area, or Northwest area, excuse me, but it's all over the country that we're seeing these things, too, which I think is really exciting.
Well, yeah, and I'm working in, I probably work less in Washington than I do any other state. So, I mean, I'm in other states in terms of seeing California, Nevada, Utah, Minnesota, Wisconsin, the Dakotas, Montana. So we're in those areas, and we're seeing some good things happening, and there's no doubt.
Excellent. Well, we'll shift things over now to Greg Rosenthal, who, as I mentioned earlier, is the Utah Flex Program Coordinator, and Utah was at the summit last year. Greg was there, and he was part of the group that helped brainstorm these strategies, and Utah has been doing some really neat, innovative work for the last few years, actually, about actually implementing some of these strategies. So we invited Greg on the call here today to talk about some of the strategies that they're using within Utah to kind of help move the needle on moving into value-based payment and population health initiatives, and kind of how they're doing some things and what their work is going on, and what their intentions are for the future, too. So thanks so much for joining us today, Greg.
You're very, very welcome, Tracy. Can you hear me?
Yes, we can.
I don't see my slides up. I don't know. Oh, there we go.
So, okay, great.
Okay, well, thank you. I appreciate the opportunity to share a few things that we're doing in Utah. I think as far as the strategies of the Financial Leadership Summit, we're using some initiatives here in Utah to help with financial and clinical and operational efficiencies. And one of our main initiatives is to work with larger healthcare systems to help our rural hospitals, which we think has been very effective. So I'll share some things that we're doing there. Just by way of background, we have 21 rural hospitals in the state of Utah. 9 are part of Intermountain Healthcare. You probably have heard of Intermountain Healthcare. They're a large integrated healthcare system that is known nationally for their work on best practices and quality of care. We have 3 for-profit rural hospitals, 2 with LifePoint, 1 with Quorum. And then we have 9 rural independent hospitals, and these hospitals tend to be your small community safety net type hospital. They really are independent. They're not part of any hospital corporation or hospital chain. So these 9 rural independent hospitals are what we've been focusing on because they have so few resources. Several years ago, we met with the leaders of these hospitals and we discussed forming a business entity for them. So we did organize them into a non-for-profit organization. They have officers, they pay dues. They're known as the Rural 9. They're scattered geographically throughout Utah, and as I mentioned, they tend to be in the small communities, safety net type hospitals. Of the 9 rural hospitals in this group, 8 are critical access hospitals. There's one that's the PPS hospital, and that's the largest of the 9. And geographically, they're spread out, and the size ranges from the PPS hospital being the largest to Milford Memorial Hospital, which has an average daily inpatient census of less than 1. So the goal of putting these hospitals together into this network, we wanted to try to reduce isolation, make them feel like they're part of a group, they have a way of collaborating together and not feeling so isolated. We didn't know when we started the network if we could really improve negotiating position for purchase services and products with just 9 hospitals, but we've been pleasantly surprised that has been the case. And even when we take a subset of this group of 9 to the table, we've found that it's quite effective. So we've been pleased with that. We're certainly able to do a lot more things and collaborate for better services and pricing than if each of these hospitals were to try to do that alone. And then our third goal of the network was to create a forum for these hospitals to network and share best practices. So just a few examples of the initiatives that we've done with this group of rural 9 hospitals. Early on, we realized that they lacked the ability to get sound legal advice. And so we partnered with a law firm based in Salt Lake City, quite a large law firm with a lot of resources, and for a very nominal fee each month, these hospitals have unlimited phone access to attorneys in this law firm. So they can pick up the phone at any time and call and ask a legal question and get expert advice, opinion. And they don't have to worry about how many times they call because there's a small nominal monthly fee. And of course, if it turns into something bigger like a lawsuit, they have to pay for that above the nominal fee. But what we've seen happen is because they're able to pick up the phone and ask a question, we reduce the problems that could happen if they don't get the advice early on. We've also collaborated with equipment maintenance, the larger equipment like in the radiology departments. Subset of this Rural 9 group, we've collaborated with mobile MRI services. All of the 9 hospitals, we took to the table for HCAP services. We prepared an RFP and we sent it out and narrowed the field down, and then the leaders chose a common vendor, and we found that's been helpful because if all the data is going into one spot, we're able to compare it and collaborate on best practices better. and all 9 hospitals are also collaborating with a group purchasing group. So that's just a few examples. As far as networking opportunities, you can see the groups here that we've formed of this rural 9 hospitals. Each group has its own personality and they do things a little bit different, but the objectives are the same. The CEOs meet face-to-face twice a year, and then they have periodic conference calls. The CFOs, they only meet one time a year. The CNOs are the most lively group. That's the nurse leaders. They meet 3 times a year face-to-face, and they take turns meeting at their hospitals. They meet for an afternoon, go out for dinner, stay overnight, and then meet the next morning at the hospital, and they have a lot of fun doing it. The HR managers meet twice a year, as do the quality coordinators. And then we just started a new group of the business office managers and HIM directors. And so what we do to form these subgroups is we ascertain interest. If there's interest, then I organize an initial face-to-face meeting. We get together, we have an education component, and then we do some strategic planning as to that group's needs. And then they choose a group leader and meeting frequency. And then once they have a group leader, I kind of fall in the background, and they own the group, but the group leader and I collaborate, and I try to help provide resources and venues and things like that. But it's really been successful for these hospitals to have the ability to get together and not feel like they're all alone. One of the main initiatives that we've done that I think is the most successful, and that kind of goes along with the strategies of the Financial Leadership Summit, is we've collaborated with larger systems to provide a lot of really good services for very low cost. And I put a few examples on this slide. Back when we were preparing for ICD-10 conversion, we partnered with IASIS Healthcare in the state of Utah, and IASIS let these rural 9 hospitals participate in all their webinars free of cost. They had some boot camps here in Utah that the rural hospitals could go and participate at no cost except for their travel and hotel and food. And that turned out to be very effective. One of our most popular programs is we collaborate with the University of Utah to provide hands-on nurse training. So the nurses from this rural 9 group, they can go to the university and they stay there for 3 to 5 days. They go with the nurses and they actually get hands-on training. To give one example of how effective that is, in these rural hospitals, the nurses, they wear many hats. They cover med-surg, they cover obstetrics, they cover the emergency department, and it's very hard for them to stay on top of best practices covering so many different disciplines. So they can go up to the university and get some real intense training on any one of those disciplines. For example, a rural nurse that spends a week in obstetrics at the University of Utah sees more deliveries in 1 week than they would typically see in 6 or more months at their facility. We've collaborated with Intermountain Healthcare to provide an annual rural hospital conference. As I mentioned, Intermountain is very good at best practices and quality of care, so this conference focuses on quality. And all of the rural 9 nurse directors and quality coordinators are invited, and then Intermountain invites the same personnel from their rural hospitals. So the rural 9 benefit from the information and the education. They also benefit from networking with the Intermountain people. Another successful initiative we did with the University of Utah is we conducted some regional department leader training sessions. In the rural hospital environment, as we know, typically an employee that's very good clinically gets promoted to be a supervisor or manager, and yet they don't, even though they're very good clinically, they don't have much experience with management. And so we wanted to try to help with that, but we knew we couldn't do it in one central location because it's hard for all the department managers to leave the facility at the same time. So we organized 3 regional trainings in different locations in the state, and the managers were able to come for 2 days. And the employee development individuals at the University of Utah conducted a 2-day training, and it was very good and very well received, and they did that without cost. We've also collaborated with the University of Utah on HR manager training, so the HR managers go to the university for a day-long seminar, and the university's attorneys have different expertise, and they share new regulations and on employment law and that kind of thing. And also the HR managers are able to develop those contacts. And the last one here on the slide is something we just started, and we're really excited about it. So we're collaborating with Intermountain Healthcare to provide monthly revenue cycle and regulatory compliance webinars. And again, these are without cost. Intermountain has a huge revenue cycle team, and so they let their experts come, and all the Rural 9 hospitals can join the webinar and learn some facet of revenue cycle improvement. And same with regulatory compliance. Intermountain brings their compliance people in. They have expertise in different areas, and they're able to share that information with the Rural 9. So we just started that one. It's been going for about 3 months, and so far it's very successful. So my last slide here, I just wanted to share with you an example of how putting these hospitals together and reducing isolation allows us to have more resources to help them. One of these Rural 9 hospitals, San Juan Hospital, a few years ago, they fell on very dire circumstances. Their days of cash on hand went down to about 10. The board parted ways with the CEO and the CFO, and they promoted the CNO to the interim CEO position. And bless her heart, she was very passionate about the hospital, but she had no background on the financial operations, so that was a difficult position to put her in. And they had 3 of their 4 family practice physicians decide to leave. So they really were in dire circumstances, and we used the network to provide resources. We got one of the CFOs, very tenured CFO, seasoned CFO, and one of the other Rural 9 hospitals, and we got him to look at their finances and their audit reports. And then we went down and met with the board and explained where they really were. And that was critical because the board really hadn't caught on to how serious the problem was. So after that, there was a sense of urgency. We approached a rural hospital CEO that had just retired, that had many years of experience, very capable. We asked him if he would be willing to mentor this interim CEO to help her with day-to-day questions, and he was great to do so. Went down and interviewed the department managers and just was kind of the interim CEO's right-hand person. And then again, we approached Intermountain Healthcare about helping with their cash flow situation. So Intermountain Healthcare sent their team down to the hospital. They spent about a week on the ground, looked at all their processes, and were able to put some immediate things into place that helped them with cash flow, which they so desperately needed. So anyway, all that assistance and some other things that we did, it's kind of a great turnaround story. I would have given the hospital about a 10% chance of survival at the beginning, but once we got all these things in place and helped them, they're doing great now. The board was able to hire a really good CEO. They recruited some physicians, some good physicians, and they're starting to turn everything around. So anyway, I guess that, in summary, we've found this idea of collaboration with the rural hospitals, especially those that aren't part of any larger organization. The idea of putting them into a network and collaborating with these different resources, especially tapping into the system resources in the state, we found that they were more than helpful. The help they looked at it as part of their mission has been a success right here in the state of Utah.
Greg, this is
That's all I had.
Thank you so much for sharing that. Yeah, thank you. I was just thinking about, my question was, like you have some pretty significant partnerships or collaborations happening with some of the, the big systems, the universities there, and wondering what the leverage point was for getting them to, help out the little guys, even if they are in a network. But I think you answered my question already with saying that those facilities felt that it was part of their mission to provide that support. Any other leverage points that the group, the Rural 9, have utilized as leverage points when working with those larger partners to offer the help that they so needed?
Well, I think it's been two things. One, we just mentioned that they look at it as part of their mission to help these small community hospitals, but we also fell into a time where these larger systems are looking to broaden their influence, broaden their network and referral base. And so they've been looking for ways to put their footprint out there a little bit more. And so I think they've been open for those two reasons mainly.
Sure. And then I guess that it makes me understand too that those larger facilities too, they want the rural hospitals to provide the care that they provide best to the rural community members that are there, but they do want them to rely on them when they need that specialty care. They need that referral too. So certainly that makes a lot of sense. There's a question in the chat box, Greg, from Kyle Cameron in Wyoming, looking for some clarification if the Rural 9 are, if they're in a nonprofit network together.
So the network organization is a not-for-profit, and the actual hospitals, they some of them are not-for-profit and some of them are special service districts. So kind of a different ownership among themselves, but the network itself is not-for-profit.
Okay, great. Any other questions for Greg? Oh, one more. And how long did it take to create the network?
You know, we applied for the network, I think it's called the Network Planning Grant. So it was, at that time, it was about $80,000, and we took that money and we invited some other networks to come in and share what they had done and their best practices. And so, and then we had another consultant come in and kind of help us on how best to organize the group. So all of that took about a year to complete before we got it up and, going.
Mm-hmm. Excellent. Yeah, and that's a great opportunity or a great synergy that you use with combining kind of two federal programs from the Federal Office of Rural Health Policy, the Network Planning Grant, along with the Flex Program Grant as well. And yes, Kyle, the Network Planning Grant still does exist. While we're moving along here, I can put a link into the chat box about the Network Planning Grant. So thank you very much, Greg, for sharing your story. Anyone else have any other questions for Greg? Okay, thank you. So, and now we'll turn things over to John Gale, again with the Flex Monitoring Team, and thankfully joining us from the airport. We appreciate John for doing that in a busy environment. And he's going to talk about some of the observations that the Flex Monitoring Team is seeing in the field on this conversion or the transition to value in rural hospitals, and how they might be folding that into the work of the Flex Monitoring Team. Thanks again for joining us, John.
I thought I had found the quiet corner of the airport, but apparently it is no longer so. But I'll hopefully it won't be too bad. So what I would like to talk to you about is where is the line of thinking that I've been doing lately around the value conversation for rural hospitals. And it's very clear to me that we probably should expand our view of value and adopt a broader view. And my reason for saying that is so much of the value conversation lately is focused on payment systems and pay for performance, value-based purchasing, all of which is important and where the systems are headed. But it's not the sole way that hospitals demonstrate their value. And I think oftentimes that value conversation isn't up front and center with the hospital. So if you look at the value-based purchasing, we're really focused on accountable care organizations, transformation activities. But I think they also need to focus on the value that they provide to their communities by dealing with issues of population health, and addressing unmet needs of the communities, focusing on some of the drivers of health and serving vulnerable populations. And while these two perspectives are often separated, I don't think they're necessarily mutually exclusive. I think they're linked in many ways. And as I conceptualize population health and how it fits into value, this next slide creates sort of my idea of graphic where population health is the center, but it really unifies community benefit and the strategies hospitals adopt to address the document their accountability to their community and address local needs. It gets to the whole issue of accountability and accountable care. This next slide came from a friend of mine and colleague, Kevin Barnett at the Public Health Institute. And Kevin's been doing sort of yeoman's work around community benefits and population health for longer than most anyone I know. And it really sort of takes a look, if you think about national health reform, not specifically in the context of the ACA or the AHCA and the sort of political football that's going on around how systems are being reformed. But we really have, over time, been moving from this very sort of traditional clinical service delivery then to moving into more community-based preventive services, and really should, as time evolves, move towards primary prevention and community problem solving. So if you look at our fee-for-service model, has moved from basically episode-based reimbursement to a certain, we've been through managed care, and we're recycling back through that with the ACOs, and ideally moving towards global budgeting. Same with the incentives. Our incentives for a long time have been to fill beds, to generate procedures. We're moving towards evidence-based care in medicine, and in going into expanded care management, and then reducing some of the obstacles to behavior change. And finally, our metrics have always been net revenue in the traditional model, but as you all know now, that we're moving towards improved clinical outcomes, reduced readmissions, moving to a more sophisticated reduction in preventable hospitalizations and emergency department use, and reducing disparities. And ideally, we're looking at improvements in health status and quality of life, along with the improved health care costs. The next slide is sort of my conceptualization of looking at a business model for CHNAs and community benefit, which is really about the whole idea of accountability, where we're aligning programs and services, looking at the needs of our communities and insured populations. Really traditional, some very much proprietary models, and what I I somewhat facetiously refer to as random acts of kindness. A lot of the community benefit strategies and efforts to address local needs have been not necessarily strategically oriented. They've been health fairs, and opportunities arise and hospitals do good work, but it isn't a coordinated strategy. So as we move to where we are now, we're focusing on the disparities and emphasizing social determinants, some of which isn't necessarily directly related to clinical services. The problem we have, as we all know, is there really isn't a lot of funding yet for, and we're not paying for population-based care, and we're building, at least starting with collaboration, I think in a very beginning level with stakeholders, and where we should be going is evidence-based, seamless continuums of care, comprehensive programs that cross sectors, aligning institutional incentives, and having one sort of collaborative player in a balanced portfolio of investments that collaborate with all players. In thinking about hospital accountability, I won't define population health. I think most of us know what it is. David Kindig has done a lot of lead work in finding this. But we really think, I really believe that hospitals need to be looking at groups, that people within their communities, they can be geographic, they can be racial, ethnic, linguistic, other categories that define some common needs or potentially define access problems and barriers, and then focus on how we improve those outcomes. What determines those outcomes